This is the webinar on scaling up virologic diagnostic HIV testing in infants and rationalizing the decentralization of testing through use of point-of-care technologies. Just as a kickoff, it is not surprising that we have made a lot of progress in accessing testing in the adult population. And one key factor that I think we need to take into consideration as we go into this webinar is that we have simplified testing of HIV in adults using rapid diagnostics with same-day results. This is not exactly the same for children, and we've struggled over the years to work around how to improve access to testing. I just wanted to kick off with a few statistics. In 2013, whereas 38% of all adults living with HIV, and I want to emphasize all adults because we're using all adults now as the denominator, not just adults eligible for treatment, 38% of them were able to access treatment. This was not the same for children. We only had in 2013 24% of children accessing treatment. And if you look at the UNAIDS WHO reports, you also see that the difference between adult access and pediatric access is increasing over time. Now, it's actually saddening that in a country like Nigeria, where we have the most populous country with a lot of children living with HIV, access to treatment in Nigeria is only 12%. Another populous country, DRC, access to treatment is only 8%. Now, we know that if we don't test children early enough, 30% of them will die by their first birthday, and 50% of them will die by their second birthday. But we also know from the SHARE study that early initiation of treatment at around 3 months of age or earlier will reduce this mortality by 75%. But we're not doing that well in making sure that children are actually tested early. And the big problem we have is that virologic testing is not accessible at the point of service. And a lot of countries are struggling with how to get samples to centralized or regional laboratories to actually conduct the test. And over the years, we've struggled with introduction of dry blood spots as a technology for sample transportation to adequately link facilities and children to centers where the test can be done. And we know that in 2013, only 42% of children actually had access to EID. Now, you might ask the question, if we're testing more children, why are we not treating as many children? Well, we have other issues that we have to grapple with. Of course, we also need to know that the population that's being tested is not exactly targeted to yield the most favorable results in terms of identifying children. But the other issue is, despite the fact that we have DBS as a technology, we really have issues in terms of still the logistics around transporting samples, and more importantly, the logistics around transporting results back. And we know that 51% of those children that have been tested in some countries actually never get results back. So today's webinar is really to look at what the guidance is around testing children, and Martina from WHO will be leading us into that discussion. And then we want to look at a country that has done very well in advancing testing to children in a national program, South Africa, and Sergio Carmona from the National Health Laboratory Service in South Africa will be leading us in that discussion. Part 2 will move forward to look at some of the thinking around point-of-care technologies and what's the pipeline for that, what's the work that's going on, and how do we start positioning point-of-care within our national policies and guidelines. So we hope that this will be an interactive process, and I'm passing it on to Martina. Martina, please introduce yourself in terms of your designation at WHO, and then you can follow up with your presentation.
Sure. Thank you very much, Harry. Greetings, everyone from Geneva. My name is Martina Pinazzato, and I'm an infectious disease specialist by background. My role here at the WHO is the IHT normative guidance advisor for the department, and I'm currently covering for the pediatric focal point in WHO. I've been involved in a number of different guidelines development processes, and in particular, since 2008, I've been involved in development of testing recommendation for infants and children. And so in my presentation today, I will be sharing some of those recommendations that are currently out there and that are part of most policies in countries. But I will most importantly touch upon a few elements that are currently under discussion and that will certainly be considered as we head to the new revision of WHO guidelines in 2015. So I will start off by reminding everyone that we have really made significant progress in scaling up prevention of mother-to-child transmission intervention. And it's clear that more firm recommendation around the use of option B and B+ have allowed initiation of treatment in pregnant women that are now receiving treatment throughout pregnancy and throughout breastfeeding. We know that a bigger number of women are now reached with intervention to prevent mother-to-child transmission, and they're also started on more effective regimen as recommended by WHO guidelines. Despite this progress, we know that in 2013, it's been estimated that about 240,000 children were newly infected, and we know that unfortunately we're still struggling to identify those children. And based on most recent data, we see that only 44% of HIV-exposed infants receive a virological test in the first 2 months by the second month of age.
Martina, sorry to interrupt. I think you need to take over as presenter in order for us to see the slides advancing. Sorry. Please proceed.
Yeah, excuse me. Apologies. I hope everyone managed to follow so far anyway. As I said, we're still struggling clearly in identifying those children that still get infected. And we know that only 44% of HIV-exposed infants received biological test.
The way it's coded in the facility, that adult first line 1A, adult first line 1B, what is equivalent?
We can see that if we focus particularly in the 21 priority countries, you can see that the coverage of EID, it's pretty diverse. And you can see there are countries that have done pretty well, like South Africa and Swaziland, and countries that are still struggling. But we can see that overall, only 6 countries among the 21 priority countries percent coverage and went beyond that. So there's clearly more to do in the next future, and we have to do it quickly. This is the currently recommended testing algorithm that was developed back in 2009, issued in the WHO testing guidelines in 2010, and has been maintained as part of WHO 2013 guidelines. So I will highlight a few key features of this algorithm. The first one was to recommend that every HIV-exposed infants would receive a test at 4 to 6 weeks or as soon as possible after that. And that test should be either an RNA, DNA, or antigen P24 test performed either in whole blood or DBS. Treatment initiation will be starting upon the first positive results. While waiting for a confirmatory test. That was also an important feature of this algorithm. At 9 months, a rapid test was recommended, antibody test was recommended in order to rule out some of those infections in those children who were not being breastfed. And finally, final diagnosis was recommended with an age-appropriate test to be performed after after breastfeeding cessation. Now, there's been significant discussion around whether particularly in light of the challenges that we're still facing in implementing EID and scaling up PID, whether these algorithms are still appropriate, and particularly if it's still appropriate in the context of larger and more and more efforts being put in scaling up PMTCT interventions, particularly with the B and B plus option. So if we think about revising this algorithm, there are three key dimensions that we need to consider, which are about when to test, where to test, and how to test. And the three questions that speaks to these three key dimensions are whether we should have a first test earlier than the 4 to 6 weeks as currently recommended, where we should be testing outside PMTCT settings, because there's a clear need to go beyond that, but which are exactly the entry points we need to consider may be different from setting to setting, and which are the technologies that can be adopted in order to facilitate the scale-up of EID. Also, are there any other innovations from the service delivery standpoint that may facilitate these scaling up further? So if we start by considering when to test, I think it's important to flag that identifying optimal timing for the first virological test means considering what the mortality pattern is, what the retention is in the program, and the test performance. And really what we want is identify a timing which allow us to optimize test performance, minimize mortality, and maximize retention. So if we start by considering test performance, it's important to reflect on what we actually mean by that. And of course, we firstly refer to the unique characteristics of the assay being used, so sensitivity and specificity of the test that we are using, but also some additional factors that may affect that sensitivity and specificity, such as exposure to ARVs as a result of maternal treatment and postnatal prophylaxis. And that has been flagged most recently as a result of scale up of option B and B plus as an element of concern that may potentially affect the performance of the test. We also need to consider when transmission occurs, and we know that without any interventions, about 2/3 of the infection would occur either during intrapartum or perinatally, and that 1/3 would happen during breastfeeding. These may actually change, particularly in light of the further scale-up of PMTCT interventions that has been achieved most recently. So when we talk about test performance, it's also important to consider performance of the overall testing algorithm. And this is because, particularly when we think about a one-test algorithm, the positive predictive value, which refers to the ability of the algorithm to adequately identify positive results, is pretty low in settings where the prevalence in the population being tested is low. And that, for example, refers to settings like PMTCT settings where successful interventions can reduce transmission below 5% and down to below 2%. And you can see that in those situations, positive predictive value is pretty low. And so it's extremely important, particularly in those settings, to combine a confirmatory test that would be repeated for those positive results. That would, in fact, increase the positive predictive value very significantly. And this is a recommendation which is already part of the WHO guidelines, but we know, and it's probably part of many policies in countries. However, we know that has not been implemented adequately, and it's something that we definitely need to emphasize and ensure is properly done, particularly in light of the emerging body of evidence that is suggesting that it may be very difficult to interpret any antibody test done in a child that was started on treatment early on as a result of the seroreversion that may occur after treatment initiation. The other element that we've just flagged is what's the impact of exposure to ARVs on the performance of the test. And while there is certainly concern around that, we can see that from a review that we conducted a year ago for a technical consultation that we had here in WHO, there's currently no evidence to suggest that there is a reduction in sensitivity at 6 weeks. And however, the studies were put together do speak to different settings and refer to a number of different type of exposures and pretty small numbers. So it's important to flag that despite these being in a way reassurance at this point, we do need more data, particularly in the context of option B and B+. When we think about test performance, we also need to consider what's the actual population that is our target for diagnosis. And it's important to recognize that, as I mentioned earlier, while 2/3 of infection would occur intrapartum and perinatally without any interventions, these may actually change as we scale up further PMTCT interventions, so that the majority of infections will then occur during breastfeeding instead of perinatally. And this is extremely important also because we are aware of a different mortality pattern based on when infection occurs. And we know that disease progression is much faster in those that are infected intrautero and perinatally as compared to those that are infected breastfeeding. And even within those infected during breastfeeding, we know that the later the infection occurs, the slower the mortality pattern seems to be. And so it's important to establish priorities to target exactly the population that we wanna reach and that we wanna diagnose and identify through our testing strategy. So what we care mostly that we really need to focus on is obviously that proportion of those that get infected intrapartum and perinatally, because we know that those are probably the ones that are contributing to that early peak of mortality that has been observed and documented, for example, from South African data, and seems to occur between the 2nd and 4th months of age. And as you can see, if we conduct the test, as we're recommending now, 6 weeks, and then in the best case scenario, get results 4 weeks after, we may only be able to start treatment after that peak of mortality and not really be able to have an impact as much as we would like to have in saving those lives. So if we were able to conduct a first test at birth and get the results 4 weeks later, then and fast-track treatment initiation, then we may be able to anticipate that mortality peak and therefore save and have a bigger impact with our testing strategy. So it's clear that in terms of mortality, having a first test earlier on may be advantageous. And what's the impact of this on the retention and in the testing cascade? And we know that there are significant losses throughout the cascade. We know from birth to return to get the test and then to get the results and then to start treatment, there are significant losses. And if we were able to anticipate all of that and test at birth to avoid that first loss, and if we were able to use point-of-care technologies to avoid that second loss, and then combine that with a decentralized approach to treatment where treatment initiation is fast-tracked and linkage to care ensured, then all the cascade and the retention in the cascade would be significantly improved. So there are obviously some advantages that have been highlighted and discussed by a number of experts. And however, we need to recognize that based on the data that have been reported from South Africa, with a very successful PMTCT program being scaled up, about 70 to 80% of infections that are detectable at 6 weeks would be detectable at birth. That's obviously a significant proportion of the total number of children. However, this does highlight that there is about 20% of those infections that would be negative at birth. And it's very unclear at this stage what would actually happen to those negative results or false negative results at birth and how we may be able to deal with those in a program setting. So there are some unknowns that are important that we should consider as we further discuss these approaches. So the other element that it's important to consider is where shall we target, where shall we put our efforts in identifying children? And it's clear that so far, a lot of the EID scale-up has happened alongside PMTCT programs. However, we know that particularly in the context of more effective regimen being used, the transmission it doesn't occur that often, and so children with HIV infection are actually outside PMTCT programs. So what we definitely need to do is to emphasize provider-initiated testing and counseling outside PMTCT programs and ensure that early infant diagnosis is actually coupled and built upon service delivery platforms that are already in place for child survival interventions. And in these slides, you can see some of the potential point of entry. And first of all, clearly sick baby services, such as malnutrition clinic, pediatric wards, and under 5 clinics are one of the most important targets for expanding testing. And because it's clear that that's where children with HIV infection are, and it's been reported a positivity rate up to 70%, particularly malnutrition clinic. So it's something that it would be really, really important to target. Obviously, there are HIV services, not just PMTCT programs, but also ART clinics. So ensuring that children of patients that are followed up normally within ART clinics should be tested with an age-appropriate test. But also it would be important to consider community-based programs that are being scaled up more and more and see how we could build upon them. And then baby services such as EPI services. And it's important to recognize, however, that some of these points may be more meaningful in some settings than others. So that brings it to the point that it would be important to consider and to tailor any testing strategy to the actual setting and adapt it to the specific country situation. So there are a number of innovations that we would need to ensure are in place, and it's not just about new technologies to be scaled up, which we will clearly talk at length as part of this webinar series. But there are a number of innovations from the service delivery point of view, from the lab point of view, that have already been documented and shown to be effective, such as the use of dedicated EID care point at facilities to strengthen the follow-up of infected patients, as pilot in Uganda. In the same country, one laboratory approach to have automate testing and maximize efficiency has also been observed to be particularly advantageous. And then Kenya has shared very good experience with the web-based platforms to improve program monitoring, monitor quality at sites. And so that's something else that could be done in countries. And there's more and more evidence suggesting that the use of SMS printers do reduce the turnaround time for the test. So to summarize, and finally, I think that it's important to remind ourselves that we have to go outside the PMTC program and ensure that testing is done at any opportunity. As we move forward, consideration to adding a virological test at birth will be important, but as we do so, it will be essential to collect the data that are that will be useful to inform policy change in the next future. Also, rapid introduction new technologies with quality assurance could be critical in further improve the tension in the testing cascade. And then linkage treatment and retention are obviously key to ensure that treatment is started as soon as these children are identified. So I think that it's important to really think about the testing strategies in the context of where we are operating, and adaptation of these strategies to the setting will be key, particularly when talking about entry points. And finally, but not less important, we'll have to make more efforts in engaging with communities and increasing the demand for testing, because there's still some reluctance from the user's point of view that we need to overcome. And it's important really to share with mums those positive stories of those infants being identified correctly and promptly, that were started on treatment early and that survive into their adolescence and adulthood. So with these, I will just conclude and leave the floor to Sergio, that will talk about the South African experience that, as I mentioned earlier, has really demonstrated very successful implementation of EID programs.
Thank you, Martina. Just a reminder to all of our participants, if you're not the presenter, please do mute your microphones so there's no feedback that can be heard. Please just bear with me for 1 minute while I upload our next slide set. And then we'll turn it over to Sergio. If there are any questions or clarification questions at this point, you can type them to the chat field. But let's please save the Q&A until the end of both presentations. Sergio, you'll need to click the button that says "Take over as presenter" in order to advance the slides. Everyone should see the new slide set on their screen now.
Great. So, can I start, Catherine?
Yes, please start. Thank you.
Great. So I guess a bit like Martina did, I should introduce myself. I'm the pathologist at the NHLS in South Africa, and together with Gail Sherman and some other key people in South Africa, like Wendy Stevens, we've been running the laboratory side and supporting the program, the early infant diagnosis program that Martina referred to. There are perhaps some slides that are complementary to Martina's, so in the interest of time and maybe to encourage a good Q&A, I will go briefly through them. The topic that I was asked to discuss in Melbourne was to give an idea to our guest, how did we scale up HIV testing in infants, and what rationale did we use in terms of decentralization of tests and the possibility of using point-of-care devices. So just to give a bit of context of the epidemic infants in South Africa, and I think to the audience of this webinar, these figures are fairly familiar, but needless to say that the burden is high in our country, with over 6 million people infected and a significant number of children. My next slide is just to show you how the distribution of testing happens in South Africa. So on the map on the far right of your screen, you can see that there are very few, 9 or so 10 labs where dry blood spots are received from all over the country. In the map on the middle, you can see that each of those blue dots signifies a potential collection point where either a mother or an infant is being taken care of. These are the sites where antiretrovirals are given. There are fewer of those that perhaps are purely dedicated to PMTCT. The scale in the red dots is just a more decentralized approach of how CD4 testing has happened in the country. But it is a fairly vast geographical target to cover, and despite the 94% that Martina alludes to as being a success, I think there's still a few that we have not yet reached, and perhaps we need to think of strategies on how to still improve on that, not only at when to test, but also, as Martina pointed out, where to test to reach that increased number. And also learning from the expansion of EID using DBS has greatly improved our... Can everyone see my slides? Yeah. So WHO, so South Africa has followed suit with what WHO has instigated. Okay, thanks, Catherine. And pretty much the protocol follows that of the recommendations from the WHO, which in essence stipulate that exposed infants should be having a virological test at 4 to 6 weeks of age or at the earliest opportunity as possible. This is obviously to start ART without delays. We know that the impact of that in reducing mortality is significant. And also infants with signs and symptoms suggested of HIV should also undergo testing. And obviously, this in the initial stages should be a molecular test. Serological testing can be performed after 18 months of age, or in some recent literature suggests maybe a little later than that because of delays in seroconversion. And how has the performance of PMTCT in South Africa been? In a recent publication by Peter Barron and Gail Sherman and other colleagues have indicated that the population surveyed in 2010-2011 reported a transmission rate that varied between 3.5% to 2.7%, and this was in the exposed population under 2 months. This is a diagrammatic representation of the guidelines that are used in South Africa and were revised in 2013, and included in that also the encouragement, if you want, of testing in symptomatic children. I think Martina had a nice slide showing what happens in clinics other than those that are purely dedicated to PMTCT. And you can see here why, for example, children that are failing to thrive should, irrespective of where they present, should be tested, because low birth weights, failure to thrive, hematological abnormalities, and other perhaps opportunistic infections are part of that whole syndrome of cases that need to be, or children that present that need to be alerted at testing. Now, in terms of performance of HIV diagnosis at different stages and vary, although I think what I would like to point out from, or maybe add to Martina's presentation, is that while the assay itself, performance does not vary from time of testing, what needs to be understood is that because of the loss to follow-up or the cascade of EID, that the denominators and the numerators change if you look carefully into those studies. So Martina is correct in saying that there's no significant changes, but there's the impact of early testing in the system is basically much higher, because you have a captured number of children that are sort of significantly high number at birth, and then it goes down as we progress. Some of these, so the effects of nevirapine and the PCR sensitivity are somewhat difficult to interpret, I would say, in the context of the few numbers that we have, but work done by Gail Sherman and I think Lilian Rivka, who is I think joined this webinar, showed that we did have more success at birth testing than in subsequent visits. I think this is a paper that has been shown as well earlier in Martina's presentation, but the effect of the number of drugs used will, in essence, have significant consequences in the target available for amplification by PCR. So you can see in the highlighted section of this table that if you use 1, 2, or 3 drugs, that the likelihood of suppression increases with the number of drugs you use, and hence the assay, the ability to pick up that signal may be somewhat reduced. Again, needs to be taken into consideration what numerators and denominators one uses. I think the Mississippi baby changed a little bit the emphasis on whether testing at birth should occur with a cure kind of agenda. I think at Melbourne we already knew of the outcome of what happened to the child, and perhaps it re-emphasizes the need of prevention over cure, but that's probably for another webinar altogether. But in essence, I think the argument still stands that testing, when to test, should perhaps still, be either at birth, because you have a higher number of chances of capturing all those children into the program, irrespective of the performance. So I think I'll go quickly through these slides as I think they're a little repetitive from Martina's, but I think what will be important in the QA session is to discuss when is it too late or when is it too early in the context of what programs are in those particular countries. So again, to emphasize, the positive predictive value varies significantly from countries that have got very well developed programs to those who have performances lower than ours. Rivka Lilian presented this in a paper a few years ago, and it illustrates the number of positive infants diagnosed at different stages. So of the full enrolled 838 children into this study, 43 were positive, and you can see that the overall distribution in the column on your left. What I would like to highlight here is that at test birthing identified all 29 cases, as you can see on the far right red bar, and of which 8, if you see testing at 6 weeks, only you can see the split here between 18 and 8 intrapartum infections versus intrauterine infections. So you can see the benefit of early testing. However, as I pointed out earlier, the denominators varied. Now, to move on to how to expand testing, I think at the time of Melbourne, we had the benefit of having recently launched this technical document, an update on implementing HIV viral load testing, and ties up very well in what approach should be used. And I would encourage you all to download if you haven't already seen this document. But it's a good approach in that it's a phased approach. So countries that have got still to develop infrastructure can tag onto these, and others that have already got a more developed system, they can expand it to increase the percentage of EID testing in those countries. So centralizing testing using DBS in high throughput labs improves the assay performance, and this has been they've been high throughput systems that we've in place, but also recently with the updated version of Roche qualitative assay to version 2, the performance of the assay has been improved. This is predominantly but for a couple of reasons. One of them is that it now is targeting 2 regions, the GAG and the LTR, and there are some assay modifications that improve the analysis of the PCR curve generated and provide a much better detection, lower limit of detection, which is on a probit 90% hit rate analysis goes down to about 221 copies. And the data not shown here also shows that there's very good performance among different subtypes as well. So it's fairly consistent. And this was also part of a poster that we presented in Melbourne, and should be available online for those who want more details. Again, where to test is still part of that question that we concentrated on. There are facilities where point of care devices may be very useful, so high birth rate clinics where exposed moms are delivering. It will be advantageous to provide a diagnosis at birth. And there are different alternatives of when to do it, the repeat testing. If obviously breastfeeding is taken into consideration, that we should also provide PCR testing post-cessation of breastfeeding. And now devices available to Do point of care at birth have been part of a Unit 8 report that has been updated by Maureen Motag in the last couple of years, and I can also invite you to see that. Liat and Alia have been tested, and Samba as well, by different organizations like MSF, and we are awaiting some of that data eagerly. So to conclude, I think PCR-based diagnosis remains the desired methodology to use at EID versus serology, and we all know the reasons for that. Highly sensitive PCR is required to implement early infant diagnosis, and now is possible at birth, at least in small settings and in our country. DBS continues to provide accessibility to hard-to-reach areas with phlebotomy skills are minimal and other clinical skills included. And point of care for early infant diagnosis could bring molecular-based diagnosis to the site of birth, and essentially also initiate those patients into treatment soon to prevent that mortality peak that Martina alluded to earlier. And with that, I would like to thank and acknowledge those who have contributed to this work: Professor Gail Sherman, Dr. Carl Techno, Ahmed, and Wendy Stevens for her leadership. Thank you.
Thank you, Sergio. I'll turn it over to Chewe in just 1 minute, but I just wanted to remind participants in the chat field, if you could, after following the webinar, please take a few moments to complete a short evaluation survey, and the link to that is in the chat field. We will have Q&A in just a minute, but I'll turn it over to Chewe for a summary and some reflection.
Thank you, Sergio and Martina. I'm not going to take over the time we have for discussion, but I think the participants will agree that Martina has clearly laid out what the key guidelines are and some of the issues that we still need to look at, especially related to performance of tests, depending on when the test is actually being taken. South Africa has highlighted as well some of these issues, and also highlighted the importance of also looking at the population that we should be thinking about, the whole issue of children that are born low birth weight, children that are not thriving, children presenting with infectious morbidity, and the ability to which we can actually optimize our identification of children by also focusing on some of these populations, in addition to the algorithm that Martina put out. And I think this is, as we think about the new generation of guidelines and how we can think about optimal approaches, we will need a better community of practice that can actually start to put out some of this data from country programs. I think, Sergio, from your lab in South Africa, you must have data that looks at what population of children are being tested and what's the yield from the different populations. We'll need that effectively, and your work in South Africa that has looked at, your positivity rates in those children that are tested at birth, having gone through PMTCT and the different drug regimens that these children would have had, this is information that we need as we think about what is optimal for countries, and the performance of the test within those different populations is going to help us. So one of the things that I would like us to really think about is, as a community, are there ways in which we can collaborate to try and start looking at different populations of children and have some real-time information around what's happening over time? Because the PMTCT program and also the HIV epidemic is not static in time, and things are changing all the time as we get less women infected, as we get more women on drugs as part of PMTCT, as we push for antiretroviral therapy rather than preventive therapy. All these things are likely to have an impact on what we do for early infant diagnosis. So I think it's important moving forward for us to continue to have this dialogue, and maybe at the next webinar series could look at those countries that are farthest along in testing babies at birth, and what are we getting from those laboratory results. So I'll pass it on to Kate so that she can start the interactive Q&A.
Thanks, Chewe. So at this point, we invite you to type your questions into the chat field. We'd like to have a discussion and a Q&A session at this point. Any questions for clarification, any questions about either of the presentations, please take some time to type them into the chat field now, and we will address them. And also just a reminder that we have a short evaluation survey that we invite you to complete following the webinar, and the link is also in the chat field. So we'll just give the participants a minute or two to type in their questions into the chat field, and we invite you to do that now.
As people are typing through, maybe I have a question for Sergio, and Martina also alluded to the fact that centralizing the laboratory in Uganda has actually improved their performance. And now this is a country that actually had tried to decentralize. I think they had 4 regional labs to try and link facilities better with laboratory and get over the hurdle of the logistics of sending samples to one centralized space. And they had a lot of issues related to that, and they had to move back to the centralized. I think South Africa has also experienced similar experiences in terms of how to effectively, in terms of the logistics, link facilities to lab. And I was just wondering whether, Sergio, you can highlight some of that. You work in the National Reference Laboratory, and I think you have the widest probably network of facilities linking into. Are there any lessons learned that you'd like to highlight?
Thank you.
Thanks.
And Sergio, I'll turn it over to you in a minute to answer Chewe's question, and then we have a question from Carusa and also from Durj. So we will take those 3 questions now. Thanks, Sergio.
Okay. Thanks, Chewe. So the experience that we've had in South Africa of decentralized, I mean, it's a fairly centralized approach, I would say. The decentralization would be sort of a mixed approach that we are considering. So mainly for specialized testing. The skills and the instruments and the lab infrastructure required for accurate, good quality diagnosis, it's difficult to expand too far beyond central areas of excellence. But the advantage of EID being based with the use of a dry blood spot is that you can increase the throughput at those laboratories without necessarily compromising access. I know it sounds a little bit sort of contradictory, but unlike viral load testing, EID testing is actually is diagnostic, not just monitoring. And we are very careful in ensuring that if it's going to be, although the guidelines, suggest that one should do a confirmatory test, we find that often, because of the cascade that Martina alludes to, that often that second test does not happen. So the approach of the centralized one is also not necessarily a logistical one only, but also to maintain good quality, and it's easier to manage that in fewer labs. And improve our logistics in terms of pickup, good quality of specimens that are packaged correctly, and preserved in the best manner possible. Perhaps there's also a number of professionals available for this kind of work. It's not necessarily an abundance, and then the mixed approach comes from trying to fulfill the gap that may not be covered in that way by considering smaller devices like point of care ones in smaller throughput areas without necessarily compromising care.
Thank you. So we have several questions that have come in. I think we'll take the first three, and then we'll answer those, and then take any remaining questions following that. So I'll just read through the questions, and then Sergio and Martina, you can provide your responses. So the first question is for either presenter: what is the average age at initiation of therapy among children? Also, countries are suggesting that birth testing may create further lab burden when they are not even able to cope with current load. What advice would you give to such countries? The next question is, I haven't heard the speakers talk about immunization as an entry point for testing infants. Can you say something about that? And the second question relates to how to link community involvement in demand creation to testing and what is needed in that field. And then the third that we'll address in this group is, do we have evidence on the effectiveness of SMS printer? In countries like Tanzania, the SMS printer has not proven to be the best innovation to increase EID uptake. So please provide your comments on that. And back to you, Sergio and Martina.
Thank you. So maybe I'll start. So there is some data being shared over the past 2 years around what's the median age of treatment initiation for children, both from program evaluation in 4 countries from work done by UNICEF, as well as observational data sets data that suggests that the median age of treatment initiation is around 5 to 6 years. So clearly very late, and clearly infants have not been identified as starting treatment as soon as they should. I think that things seems to be changing in many countries. However, we still don't have robust evidence to sort of show that. But things seems to be improving, at least in the Southern Africa IDEA collaboration. There's been some suggestion that there is an increase over time of infants being started on treatment. However, the median age still remains fairly high, certainly not optimal. So that's the first half of the first question. The second half is about increasing the burden in labs that are already struggling. I think that, it's clear that testing a birth as it is right now means adding one test, and that is going to be that will mean increasing resource, requiring more resources, both for the work in terms of workload as well as costs, obviously, and that's something that needs to be taken into account. And I think that's probably why some of the pilot projects that are currently undergoing will be extremely important in sort of providing these informations, not just at the level of performance of the test, but also what these potential policy change could mean at the program level. So I think we need to learn things, and we need to probably link these challenges and these pilot projects to actual outcomes, and so see how these will turn into more children being started on treatment. Maybe we can move to the second. Second question is about immunization clinic, and I think I referred to that when talking about moving treat testing beyond PMTCT programs. And I think that there are a number of experiences in that there is not consistent. There's no consistent view on whether this is something that works everywhere, and I think that it will be important to consider the different settings. And it's clear that when HIV prevalence in the population is higher, there's more rationale for having such an approach. However, I think that what it would be extremely important is to also see what's the potential impact of providing HIV tests in EID, EPI in terms of uptake of EPI itself. There's been some reluctance in some settings in adding HIV testing, with the concern that moms may not come for immunization, and so that would negatively impact the uptake of vaccinations, which obviously that's not something we want to do. However, that's not been consistently observed across settings and experiences, and therefore I guess that many of colleagues will really endorse the fact that we probably need more experience and more data.
So This is Sergio. So I would like to add to that. I think the principle is the same, that a child that presents with symptoms or falls into the category of being tested, I think every opportunity that we have it should be taken into consideration. Now, do we know the impact of what would that be? No, we don't in all settings, but in South Africa, some of these testing was linked at the beginning through an EPI program because it was captured there. Obviously, now to add to the issue of testing at birth and burdening the lab, I think we don't know what the outcomes are and how many. We have very little data to link outcomes now to how many babies will we be saving and how many tests would that require and what the burden would be later on. But it could potentially create some burden in some labs. Now, there was a question there, a clinical question. Catherine, should we leave it up to you?
You can go ahead, Sergio.
I think there was another question about SMS printers.
Okay. Do you want to take it?
Well, I do think there is evidence, essentially, a number of papers that do support the use of SMS printers, and I don't know whether any colleague from CHI is part of the webinar, but certainly CHI has had a lot of experience with that in EID programs, and that's been documented. So there is evidence, and we're trying to gather the evidence and review it systematically for the next round of guidelines.
Sergio, did you want to answer the clinical question? And then we have another group of 3 that I can address after you've answered that one.
Community?
No, so I think it comes from Kajendra Prakash. So she states that 3 children show DNA and antibody test negative after 18 months' time. Went her to continue. I presume that the DNA test was positive. Is that what she's testing, right? So in essence, I think we know that seroconversion in children can be delayed. I mean, I think a few papers showing that it can be up to 20 to 22 months that we see evidence of. So I wouldn't, if there are 2 DNA positive results, and it's a difficult one, but I would consider that child positive. I don't know, Martina, what?
Yeah, I think these examples really flag the importance of getting the diagnosis right at the very beginning with a confirmatory test. I mean, there's more and more evidence becoming available in documenting seroversion, so antibody negative in children that were started on treatment as a result of positive DNA results. There has been one case reported, at least at CROI from Malawi, that reported not just negative antibody tests, but also negative DNA, which is what you're referring in your question, I believe. I think that there's probably more to investigate in those cases, and I think that it's subtypes maybe, but not. I'm not entirely sure the subtypes. I mean, my understanding is that the assays we have right now
we know that perhaps interaction.
I just wanted to actually say that these are some of the complexities that we have with pediatric HIV, especially in settings where we don't have the lab capacity to maximize what we do in addition to diagnosis. So many countries are doing the DNA test. And in most countries, it will be the one test that they'll do. But, if there's been more than one positive DNA, we could assume that this child was definitely infected, and that we know that the impact of early treatment, depending on when this treatment started, does impact on our ability to actually pick up positive antibody testing. Because when you have maximum viral suppression, we know from the Mississippi baby that that also impacts on the immunological response in that child, and that I think we're going to start picking up a lot more children as we test them early and start them early on treatment. And I think the importance, again, as I said, of keeping ahead of some of this and documenting it. I think these are the type of children that probably need more than a DNA test. We need to be looking at evidence of infection by looking at viremia as well. But all those things do add to what we are already doing from a public health approach. And my response would be not to stop the treatment. I think it's the importance of continuing, because we don't know whether this child has, viral reservoirs that we're not just picking up through our normal DNA and antibody testing. So I agree with Sergio that this child probably needs more investigation to look at what's going on.
But one thing I would like to add, Chewe, is that we know also that treatment interruption is not advisable, right? I mean, that's when, reservoir could increase, etc. So I think, so this puts into context the whole webinar about the quality of these laboratory tests in the context of where the samples are being collected is critical. And also understanding the consequences of perhaps early testing, interrupting treatment, etc. I don't know if you want to move on to some of the other questions.
Yes, we'll move on to the next group of questions. I just wanted to mention that one of the participants asked about the presentations. We will be sharing both the presentation slides and the recording of this session on the HIV point of care community of practice. And if you're not already a member of that, the link is in the chat field, and you can click on that and register to receive the access to those materials. So the next group of questions, we have one from Jacqueline in Malawi, who asks, virological testing at birth has several benefits rather than later. Is there a specific timing recommended for optimal results during this time? And Carusa asks, what is the average cost of a virological test, DNA PCR? As I had understood that Samba is already available and on the commercial market, according to their agents at IAC in Melbourne. And what has been the experience thus far? And we'll take one more. This group, Victor, asks to Sergio, how good is the linkage to care for children testing positive in South Africa? And what interventions would you propose for countries such as Uganda, where despite the exemplary EID lab performance, we still have about 50% of the positive children not being linked to ART care? So over to you, Sergio and Martina.
We're just busy unmuting. Okay, I think the question from Malawi. So refers to birth testing has several benefits. We will discuss those. Is there a specific timing recommended for optimal results during this time round? So I think we have very limited experience. What we're trying to do in South Africa is to provide those within 48 hours, mainly because these protocols were designed during around what had been reported during the Mississippi baby. So the intention was to start treatment as soon as possible. This is obviously in very defined and well sourced settings. I wouldn't put that in as a recommendation or anything. I think for now, I don't know if Martina agrees, but we need to gather data to be able to provide that as a recommendation. But it's purely in a very small setting to study the intervention. With regards to the cost of virological tests, DNA PCR, these vary in country significantly. WHO, UNAIDS, and others are trying to get to that and make it more affordable. With reference to Samba and data available, I think MSF has got some experience with that, but not. They have had some studies reported, and it's fairly new. So I personally can't report on experience in program settings.
So data for Samba were presented at IAC in Melbourne. However, there's no public data being shared so far. So we're looking forward to see that.
I think CDC has got some in Kenya as well. Some. Then Victor has got a question for me. So with reference to linkage to care, there's obviously room for improvement in that sphere. We in South Africa have a centralized laboratory network that we are able to pool all the data nationally with coordinates of where these positive rates come from. I think a couple of things that have been designed are dashboards and reports that go to clinical managers, etc., to provide a tool for those children to be followed up and as you said, provided ARVs as soon as possible. I think there is some mobile health device approaches that have been also investigated to be able to notify moms or healthcare providers of these results. There are a few sort of ethical, if you want, barriers to overcome in how we transmit sensitive data and to ensure that it's done in a secure manner and that sort of protects the privacy of the child and the caregiver too. But those some approaches used to improve the care. To improve that positive result actually effectively resulting in a child being put on treatment, if you want.
Thanks, Sergio. And just a reminder to all participants that the part 2 of this webinar series will focus on point of care. And that will take place on the 30th of September at the same time, 9 a.m. New York time. So we may wish to hold off on some of the detailed questions about point of care until that second webinar. Amelia from CDC writes that SAMBA and other point-of-care EID tests have not yet been independently evaluated, meaning by funding by someone other than the manufacturer. And WHO is developing guidance on how to evaluate these tests and asks, is there an update on when this guidance will be released? Martina?
Yes, so I can confirm that only a couple of platforms were submitted for pre-qualification for WHO. So yeah, I absolutely agree with Emily's point. As she mentioned, there is some work ongoing in setting standards for field evaluation for point-of-care technologies. That's a process that has been led as a Unitate funded project by Rosanna Peeling at the London School of Hygiene and Tropical Medicine in London. And as far as I can tell, the process is still ongoing and under finalization. I'm not aware of any specific timeline for the final release of such guidance, but I will get back to the group as soon as we have more information about that.
Okay, thank you. Any further questions? We invite you to write them into the chat field now. Just a reminder that the recording and the slide sets will both be shared on the HIV Point of Care Community of Practice. If you're not a member, please join. The link is in the chat field. Also, just a quick reminder to complete the short evaluation survey following the webinar. We'll be wrapping up in just the next minute or two. We've already gone past 1 hour, so if anyone has any final questions, please write them in now.
Katie, while people add questions, I just wanted to emphasize a little bit the fact that the existing algorithm that is included in the WHO 2013 guidelines is the one that countries have adopted and should be followed. And so going back to some of the questions that were raised around how many PCR should be done and how the test should be dealt with, I think we still need to stick with that algorithm. So a positive test followed by a confirmatory positive test is an infected infant that should be started on treatment, and that child should not be retested for significant reasons. So treatment should be continued and not stopped for any reason. And if the second test is negative, that will be different, obviously, and a third test will be required to deal with that discordant results. And that's been clearly outlined in the 2010 recommendations and re-emphasized in 2013 recommendations. Finally, I wanted to flag that while we all believe that testing sooner is better than testing later, and testing at birth has important potentials, both programmatically as well as in terms of ensuring that fecal mortality is avoided, it's extremely important for people in the webinar that are part of organizations that are piloting this approach, that data are collected, and that those negative results that are observed at birth should be carefully monitored so that we have a better understanding of what's the implication for that. Because clearly there will be a focus in the next guidelines revision on this, and it would be really important to have more data and more information. So this is very much a plea for those of you that are out there in the field and thinking about piloting these strategies to do so, and make sure you collect the data that we can use for policy revision.
Thanks, Martina. And Deo just adds, in addition, some countries have developed POC diagnostics technology evaluation protocols with support from UNITAID. We do have one final question related to community involvement, and then I think we'll have to conclude, and I'll turn it over to Chewe once Sergio and Martina have answered this question. It's what is needed in community involvement? I cannot recall if heard as a response to that question.
So I mean, community involvement is essential, from prevention to education, and also to ensuring that these children are kept in care. I mean, I cannot emphasize that stronger. I mean, the programs are not successful purely because there are laboratories available. Without community involvement in terms of understanding, this cannot, it wouldn't succeed. And I think for those who recall one of my slides where you see that old lady, she's the granny, she's sometimes the caregiver, that often, purely because of education, brings children to the clinic for testing, not knowing necessarily if the mother is actually positive or not, purely because the community is encouraging children that are sick or fall under those criteria that Martina and I discussed that need and should be tested. So perhaps it's a little bit beyond the scope of this webinar, but it's certainly a key point that could be discussed further for improving the success of EID and PFTCT in general in many of these countries. I don't know if, Martina, you got something more to add.
Well, I think that what would be critical, it would be to sort of convey that message to the community and through the community that testing is not, it's actually the opportunity to have access to treatment and to prolong and save lives. And I think that we still have to deal with a lot of stigma attached to HIV testing and HIV diagnosis, and that's the reason why a lot of moms don't accept HIV testing in many settings, and that's something we have to change, and we have to change together with the community, because it's something that they will be ultimately the true enablers of scaling up EID. I mean, all the technologies and the best strategies won't work if the acceptability and if the uptake of the test won't be good enough. So there is more work to do, and probably we still need to have more discussions within partners and with those of you that are that are working in the field and working in countries directly in the community to ensure that we focus our efforts in really having more work around demand creation and conveying those messages that will be critical to increase uptake.
Thank you. I will turn it now to Chewe for some final words, and just a reminder to fill out the evaluation survey and to join us for this second part of this webinar on the 30th of September.
Thank you. I think it's been interesting listening to some of the questions that have come through, and maybe I'll summarize that a lot of the questions that came through just tell us about how many operational issues we still have in terms of program implementation and translation of guidance into something that would actually benefit children on the ground. I think what came through is definitely that the whole idea of optimizing what we do in relation to what the epidemic is telling us in a country is very, very important. So in terms of in terms of geography, we need to optimize our testing. But I think within that, there was a lot of discussion around how do we optimally link facilities to the lab, and what would be optimal, and the whole discussion around centralized systems and the importance of that if we have to maintain quality. But at the same time, we also are struggling with how to optimize as we think about quality and the lab. How do we optimize access of testing to children, and what came through around DBS and SMS printers to try and link facilities better with laboratories is something that we're still working through as a community. And then, of course, there were lots of things around population. Now, in most settings, there's a big effort around making sure that children that are born to mothers that have been tested to PMTCT are actually tested according to the WHO guidelines. But there's this other space which is very much linked to the epidemiology and our response of children of unknown exposure that are ending up in the different places. How do we optimize what we do with those? And there was a question around immunization and how do we effectively use immunization points to actually identify. I think for me, in summary, all this points to the importance of continuing this conversation as we think about the new and the ambitious treatment targets of 90-90-90, where we really want to make sure that 90% of children that are infected are actually identified and linked into services for treatment, and that we will have to actually look at what are some of the optimal approaches to effectively do this. And this was an exciting beginning. I just want to remind people that as part of this webinar, we will follow through next week with the webinar on POC. And there were a lot of questions around what do we know, what are we seeing in terms of evaluations of SAMBA, LIAT, and LALIA. And that will be discussed next week, because some of the people that are leading some of the evaluations, like Hileshi in Mozambique, will be part of that discussion. But I think this is important, and we need to look at the space of POC and take into consideration some of the caveats that Sergio and Martina were starting to talk about around quality. And so as we think about POC, there's something to be said about what will be the role of the centralized labs in making sure as we decentralize, we do actually get quality results, especially in this space where one test could mean a lot for the child's life, but also the importance of what we do in the case of having one test and then the other test negative, or when we have negative results after initiating treatment. So it's a very fluid and difficult space for us to operate in, but we do need to have the conversation. And thank you for all those that actually participated.
Okay, this concludes today's webinar. Thank you again to our presenters, Sergio and Martina, and thank you to all of our participants for joining today. Just final reminders to please complete the short evaluation survey, and to mark your calendars to join us on the 30th of September at 9 a.m. New York time for the second part of this webinar that will focus on point of care. So thank you again to everyone, and have a nice day or a nice evening. Thank you. Bye-bye.
Thank you. Bye.